The patient is a 63-year-old woman with a large caval sarcoma. All three hepatic veins were obstructed, leading to a Budd-Chiari situation, rendering all but an ex vivo approach unfeasible. The sarcoma extended from the renal vein caval confluence to the cavo-atrial junction, with anterior extension displacing the porta hepatis, but without portal vein invasion. The tumor arises at and before the junction of the anterior cava with the right and left renal veins. The kidneys and lower extremities are draining largely through a posterior lumbar vein, located at the level of the renal veins. An ex vivo liver resection with en-bloc resection of cava, backbench liver flush, segment 167 resection, with creation of liver segments 2, 3, 4A, 4B, 5, 8 autograft is planned. The cava will be reconstructed with a 19 French ringed PTFE graft. The suprahepatic IVC will be mobilized up to the atrium, and the infrarenal IVC will be fully mobilized for later clamping. Following a cholecystectomy, the porta hepatis will be dissected, and the right gastric artery and GDA will be ligated and divided. The common bile duct, right portal vein, and right hepatic artery will be dissected free, and the common bile duct will be divided sharply. The SMV will be dissected and mobilized. Bovine pericardium extensions will be fashioned using a vascular stapler and cut on an angle. The extensions will be sutured to the SMV and, after clamping, to the infrarenal IVC, connected with a Y junction, which is then connected to an ECMO circuit for a veno-veno bypass. The extensions offer the benefit of reduced operative time and increased vascular integrity post-operatively. Blood flow returns to the patient through the right internal jugular vein. The veno-veno bypass will be instituted. The portal vein will be clamped. Hepatic artery will be clamped. Both renal veins clamped. And suprahepatic IVC will be clamped. The portal vein will be divided. The infrahepatic cava will be divided below the level of invasion and above the level of the renal vein confluence. The suprahepatic cava will be divided, followed by division of the hepatic artery, and the liver will be removed for backbench transection, while the caval reconstruction occurs simultaneously. Liver transection will be carried out in the cold, resecting the right posterior sector and caudate lobe en bloc with the cava and sarcoma. The segments 2, 3, 4A, 4B, 5, 8 autograft will then be brought back into the surgical field. The cava will be reconstructed with a 19 French ringed PTFE graft, with a diamond-shaped opening made at its superior end for hepatic vein reconstruction using the autograft middle left hepatic vein orifice. Following hepatic vein reconstruction, the portal vein will be reconstructed end-to-end, clamped distally, and the proximal clamp released. The veno-veno bypass will then be stopped, and the bovine pericardium extensions stapled off and divided with a vascular stapler. The portal vein clamp will be released, followed by removal of the IVC clamps. The hepatic artery will be reconstructed using a parachute technique, the arterial clamps released, and the bile duct reconstructed end-to-end.